Hello everyone. Back again for another episode of Insight Matters. This is a solo episode. It's a Biome Bite. And today we're speaking about using gut microorganisms to treat cancer. Now, before I jump in to the detail of the podcast, I wanted to say a big thank you to everybody who's taken the time to support the podcast through leaving a 5-star rating on Spotify, Apple Podcasts, all of the platforms that we're using. A big thank you to all of those who subscribed, and a big thank you to all of you who have written directly with suggestions, with questions, with feedback. It's very much appreciated. The best thing you can do to support this podcast is liking, subscribing, and giving a good review, because it pushes us up on the algorithms, and that enables more people to listen to the podcast. And what we're all about here is providing people with easy to understand, high yield, high impact information to allow them to learn, take action, improve their health, or improve the health of others through imparting that knowledge. Moving now to today's episode, using gut microorganisms to treat cancer. I'm really excited about the potential of the microbiome across the entirety of the field of oncology and immuno-oncology. Oncology being cancer and immuno-oncology being a subset within the field of cancer where you use the immune system to treat particular types of cancer. And that's specifically what we're going to be speaking about today. But taking a step back, let's just talk about what cancer is. So essentially it's a broad term used to describe a group of diseases that is characterized by uncontrolled growth and abnormal spread of abnormal cells across the body. And typically cells do grow and replicate, but the immune system and the cells themselves keep the growth in check, so you don't get uncontrolled growth. But in cancer, the cells themselves can become abnormal, and as they become abnormal, they become very good at hiding themselves and evading the immune system. There are more than 100 different types of cancer. They're typically named after or for the organ or type of cell in which they originate. So prostate cancer, for example, breast cancer. And I read prior to doing the podcast today that 1 in 2 men and 1 in 3 women will be diagnosed with cancer at some point in their life. And that doesn't necessarily mean they will die of cancer and it will be a horrible death, like, to be honest with you, all of us will be familiar with. Some people just live with it, and many men have prostate cancer, but it doesn't get to a stage or size where it leads to their death. But of course, young people do get cancer, and it can be absolutely devastating for patients and for their families and friends and everyone around them. And we've done a lot in recent times in modern medicine in improving our diagnostics, our screening, and our treatment. Today we're speaking about treatment specifically. So just a very, very quick overview of the different types of treatments before we start speaking about the immunotherapy side and how the microbiome may impact on immunotherapy. So what can you do when you've got cancer? Well, you can cut it out. So there's surgery. This is the oldest, perhaps most well-established approach, and it's still used very, very often. There's chemotherapy, which are essentially kind of chemicals or substances which stop cells dividing, and of course they stop various different types of cells, including the cancer cells, and as such they're associated with side effects and what we call toxicity. There's radiation therapy, so high energy rays, which again disrupt the inner aspects of cellular machinery and stop them from being able to replicate, and we can do this in a very, very precise, accurate manner now, with improvements in kind of lasers and the beams and using technology to be able to pinpoint exactly where they're going to focus in on. So there's been improvements there as well. There's also hormone therapy. So some cancers grow in response to hormones. So if we block those hormones or block the hormones at the site, if you like, of the cancer, then that can slow cancer growth down. There's no treatment. Sometimes you just watch and wait. If it's known to be a really slow growing type and the patient's of a certain age or they've got comorbidities or just their choice, you can watch and wait through regular surveillance. We have things like stem cell bone marrow transplants, which you've probably heard of, where you essentially replace destroyed bone marrow, and that bone marrow is the source of blood cells. And the bone marrow is destroyed through really intensive chemotherapy, radiotherapy regimens, and then you can receive the bone marrow back from a donor or from yourself. There's also what we call more targeted therapy. The classic one is Herceptin, and in patients with breast cancer, there's this overexpression of something called HER2, which is a protein, and if you essentially inhibit the HER2 through an antibody, then you prevent the HER2 expressing cells, which are cancerous, from receiving growth signals, and then they kind of stop growing. So there's that. Then we've also got immunotherapy. There's a variety of different types of immunotherapy, and I'm not an expert in immunotherapy, or an expert, to be frank, in cancer therapy, but I know enough about it to be able to give some decent background here, I think. And if you're enjoying it, let me know, and we'll get some experts on to talk about advances in cancer therapy, maybe even beyond the microbiome, because it's fascinating for me. So what is immunotherapy? Well, first and foremost, I think it's important to say that it has revolutionized cancer care for many patients, and some of the responses have been staggering. It essentially uses the body's own immune system, which is the master regulator of uncontrolled cell growth, to get better at attacking cancer cells, which are good at evading and cloaking themselves and hiding themselves from the immune system. And in particular, I want to talk about something called PD-1, PD-L1 checkpoint inhibitors, which have profound impacts on many types of cancer cell, not all types of cancers, but many types of cancer cell. And the PD-1 checkpoint inhibitors, PD-L1, are some of the best-selling drugs in the world. To give you an example, Keytruda is a multi-billion-dollar-a-year drug. So PD-1 is a protein on the surface of something called a T cell, which is an immune cell. And PD-1, the protein, binds to something called PD-L1 on cells and acts as an off switch, essentially, telling the T cell to leave the cell alone. But some cells express very large amounts of PD-L1, cancer cells in particular, and that allows them to evade the immune system. So these inhibitors essentially block the interaction between the PD-1 and the PD-L1, which allows the immune cells to attack more of those cells. And in cancer cells, which are good at essentially producing the PD-L1 and essentially hiding themselves from the immune system through that checkpoint or through that pathway, it then essentially releases the brakes and allows the immune system to go and get it. Some patients have phenomenal response where the cancer essentially just disappears. Some patients have partial responses, and some patients have no responses where it's kind of refractory to treatment. And what doctors do is they try different types of combinations, and there's constant evolution in the treatment algorithms, trying different combinations at different stages and different cancer types with additional medications on top to try and potentiate PD-L1s. And what we've learned is that a proportion of patients just simply don't respond. And I had written down here that something like 50% of patients with advanced malignant melanoma experience some sort of primary resistance, so resistance to the first treatment option. That's a lot. And the microbiome, as you'll know if you've been listening to this podcast, has an impact on the immune system. There is 24/7, 365 bidirectional communication between the immune system and the microbiome. And that communication starts from birth, essentially. And the microbiome and the immune system have this intricate relationship where they kind of train each other, or the microorganisms train the immune system and dampen down the immune system, but also potentially potentiate the immune system when it's beneficial to do so. And this might be one specific case. So early work in this field, dating back to 2018, profiled the microbiome in responders and non-responders and started to elucidate some trends. They were that higher diversity, which is a principle we've talked about a lot in this podcast, is associated with response. Lower diversity is associated with less or no response. Some microorganisms which can be described as kind of pro-inflammatory are associated with non-response, and some microorganisms which produce things like short-chain fatty acids are associated with response rather than non-response. And interestingly, actually, some of these microorganisms that were identified in this field, or the subset, if you like, were also identified in other fields, like, for example, being potentially important in liver cirrhosis and something called hepatic encephalopathy. And when I've learned that there are bugs which come up again and again, and trends that come up again and again, and that we don't really know what that means. But it might be that there are good actors and bad actors, and they're consistently bad and consistently good, although I think it's important to note that no one microorganism is universally bad. It's also context dependent, and also no one microorganism is universally good. It's context dependent. So there was that work, and then there was also some work which identified that antibiotics in patients who were taking PD-1, PD-L1 checkpoint inhibitors were associated with non-response. And antibiotics reduce diversity. They have a negative impact on the microbiome, and I think that started to stimulate people's thinking. Then there were some mouse model experiments which used PD-1, PD-L1 checkpoint inhibitors, and in which stool samples were taken from responders, non-responders, and moved into the microorganisms. And indeed, the stool samples from the non-responders, when introduced to the mice, essentially prevented response to the checkpoint inhibitors. And on the other hand, a transfer of microorganisms from a responder into the mouse enabled the mouse to respond to PD-1, PD-L1. So that was some mechanistic data. And then everything changed in 2021 when there were 2 papers published in the journal Science. One group based in Israel. I really hope I've got that right. The other group was based in Pittsburgh in America, and that was the Dibber-Carr-Devar group. And essentially what they showed, and the trials were designed differently, and indeed the key differences in terms of how the material was administered and what stage the patients were at, and importantly the pre-treatment as well of patients was different. And in one of the studies they gave high dose of antibiotics before giving the treatment, and we're going to talk more about that in a little bit. But that's what some companies and some investigators have done to try and improve what people call engraftment, which is a controversial term, but broadly speaking refers to microorganisms which were or are definitely present in the input material or product, finding their way into the intestinal tract of the recipient and sticking around, essentially, and persisting. And those microorganisms are not there prior to the intervention. So they can move from the product, the donor, into the patient and stick around. And some people think that engraftment, this what we call primary engraftment, there's also other types of engraftment where microorganisms from the environment might find their way into the recipient as a result of the microbiome intervention. But a lot of people speculate, and there's some work that does suggest, it's not proven yet, that engraftment may be important in the context of whole community FMT, IMT, intestinal microbiota transfer efficacy. So these patients, in summary, what I have in my notes is that roughly 30% of the patients who were non-responders after first line, or maybe second line as well in some cases, therapy, became responders after the FMT. Now, the one key point here which I want to emphasize, the FMT was prepared using samples from patients who had responded. What was the rationale there? Well, I think the rationale is if the microbiome is important and patients have responded to PD-1, maybe it's the microbiome that's made them respond or not respond to PD-1, PD-L1 checkpoint inhibitors. And if that's the case, why don't we just take a microbiome sample from someone who has responded and process a product and move that into patients who've not responded? And I think that also follows the logic of the animal model experiments as well. And I get it. I think it's really quite interesting. And I've heard other things as well, just to go off on a little bit of a tangent, if you don't mind, such as, well, if you've got a very, very strong family history in one family of disease X, call it inflammatory bowel disease, but one person doesn't have it, is their microbiome protecting them? And if so, maybe we should move that microbiome into other people who have a high risk or who have the disease to see if it helps treat them, because it maybe has some currently uncharacterizable protective properties. Now, I'm running a company that's developed a standardized, full spectrum, broad consortia therapeutic, which is donor derived, but achieves consistency and has a higher diversity than individual donors because of the methods of manufacture. And I don't believe that collecting samples from patients is a scalable and viable approach to be able to maximize the impact of using gut microorganisms to treat disease. And I just am a little bit uncomfortable with, taking a microbiome sample from someone with cancer and, because that's not a healthy microbiome, I don't think, and moving it into a patient. I just am a little bit uncomfortable about all of that, and might try and get the authors on to have a debate about this, because I've had the debate with them away from the podcast. So these were, I guess, seminal papers insofar as they advanced the field significantly. They're now quite highly cited, and I think they got everyone else excited about the microbiome and cancer, including those who were previously very skeptical, because you had this observational kind of sequencing data, the antibiotic data. Then you had some mechanistic data in animals, but I think the skeptics would say, well, it's just animals and it's just observational. Then when you do something like this, when you actually take samples from responders in humans and move them into patients who've not responded and make them responders, okay, that's a big deal. Now, there were limitations of the studies, of course. They were small. They were not placebo-controlled. And there were limitations in terms of all the data that was collected, the follow-up, and I suppose, in some respects, it is relatively difficult to compare FMT study to FMT study, where the methods of preparing the product are so different, because you're probably giving a different product. And there's often a call for standardization in this field, although standardizing a donor-derived product is challenging. And that's what I've spent the last 5 years of my life trying to do. So moving on now to a paper that's been recently published and that stimulated my thinking with regards to doing this Biome Bites episode. Now, before I jump into this paper, which I have in front of me and that I've read many times, I've also spoken to the chief investigator of the study, Salban Malik. If you've enjoyed everything I've just talked about with regards to those two papers published in Science and the background to this field, please write to me, because I could do a longer episode on it and talk all about the trials and how many patients were treated, what the design was, and what was the pre-FMT intervention, what were the specific drugs that the patients were taking, what were the characteristics of the patients before they had their intervention and after the intervention, were there any microorganisms associated with success or not, has there been any follow-up, what are the investigators doing now? Please write to me and let me know, because I'd be very happy to do that. And I really enjoyed preparing for this episode because it gave me a kind of refresher, and it's great to stay right on top of all the literature, even as a CEO, rather than being a chief scientific officer or chief technical officer or whatever. So now the background to this, as I've said, is that FMT is a potential strategy to overcome resistance in refractory malignant melanoma. So that was a key point. Those two studies were in patients with malignant melanoma, so basically skin cancer, an aggressive form of skin cancer. which affects young people and can progress very fast and be fatal. But they were in patients who were refractory, and the samples were collected from patients rather than donors. So what this group did, based in Ontario, Canada, Dr. Malik, they said, okay, there's limitations associated with that, and could we bring it further up the care pathway? So that instead of waiting for people not to respond and having to go through all the treatment with associated side effects and toxicity, and some patients maybe die, what about in a first-line upfront treatment setting? Can we combine FMT with the current standard of care to potentiate the standard of care and make it more effective, maybe better tolerated, maybe safer? So they did that, and they also did it with a healthy donor or healthy donors. And I think that's really important, because that is, for me anyways, a more viable approach longer term, a more scalable approach longer term. So I've just had to do a quick reset because there was some sun coming into my eyes, and there still is some sun coming into my eyes, but that is quite a rare event here in Bells Hill in Scotland. So now moving into the paper published by Dr. Saman Malik. The title of the paper is Fecal Microbiota Transplant plus fecal Microbiota Transplantation plus anti-PD-1 Immunotherapy in Advanced Melanoma Phase 1 Trial. Now, for those of you not familiar with the phraseology Phase 1, Phase 2, Phase 3, it's quite subjective, and there's no book which is universally agreed across the world that says this is a Phase 1, this is a Phase 2, this is a Phase 3. So there's a little bit of subjectivity there, but typically if an intervention's been given to people, for the first time, it's a Phase 1. If there's no comparator or placebo control, it can be a Phase 2, although again, there's some dubiety there because you can get some Phase 1 studies that do have a placebo control. So there's a little bit of subjectivity there in terms of what makes a Phase 1, a Phase 1, a Phase 2, a Phase 2, a Phase 3, a Phase 3, but you go sequentially from Phase 1 to Phase 2 to Phase 3. Big picture, the studies get larger as you progress. Typically, Phase 1 is to establish safety and tolerability, as well as how the drug interacts with the body, pharmacodynamics, and also how the body interacts with the drug, the pharmacokinetics, and how the drug substance essentially moves around the body and through the body. So, and then in Phase 2, you start to test preliminary signals of efficacy. Sometimes they can be statistically powered to try and overcome to reduce the likelihood of an event or an outcome happening by chance. And then in Phase 3, you would typically compare the drug with the existing standard of care in a statistically powered setting, and classically the p-value is less than 0.005. The p-value meaning the value associated with the statistical probability of the outcomes happening or not happening by chance, so 5%. Now, in this study then, the team at Ontario, Canada, based within Ontario, Canada, decided to take a step forward, and they looked at the limitations associated with the work that had been conducted previously, as I mentioned, and decided that they wanted to give FMT microbiome modulation upfront rather than as an intervention once patients have not responded to the immunotherapy. And they also wanted to use donors rather than collect material and use material from patients who had responded, which is, in my opinion, a good thing, because I think that's a more scalable and realistic approach. So they used 3 different donors over the course of the study. There were 20 patients who received the FMT plus immunotherapy intervention, and they measured safety and tolerability, or safety as the primary endpoint, then looked at a variety of different outcomes relating to potential efficacy, which are known to people who are involved in the oncology field and the cancer field, and I wouldn't get into the specific details. But big picture, it's called objective response rate, They classify that based on partial response, non-response, complete response, and that relates to what happens to the cancer cells within the body after the intervention. So some patients experience adverse events, but the outcome of the study suggested that there were no more than you would typically expect to see in an immunotherapy study, which is positive because that suggests that adding the FMT or the IMT, whatever you want to call it, doesn't have a negative impact on the safety and tolerability profile of the drug. And actually, some investigators in this field think that an FMT IMT could really enhance the safety and tolerability and the side effect profile of drugs, like chemotherapy, for example. That could be huge. If you could increase how much chemotherapy someone can tolerate, then you might be able to enhance the effectiveness of chemotherapy. And we all know how horrible the side effects are associated with that. So this, they reported that 13 out of the 20 had an objective response as classified, and 4 of the patients had complete response, which is good. And in the paper, they compared that to what you would typically expect to see in PD-1 checkpoint inhibitor therapy based on the large phase 3 studies that were conducted by the drug companies in this indication, which I thought was very interesting. And in addition to that, they also had a look at the microbiome before and after the intervention and tried to decipher, are there any trends associated with those who did respond and those who didn't respond? And one interesting finding was that the microbiome profile of those that did respond became more and more similar over time to the donor samples. And this gets back to this discussion about engraftment. The patients who did respond kind of took up the microbiome profile of the product and then accepted it, whereas those who didn't respond didn't. Maybe that's something to do with your immune system. Maybe it's something to do with the baseline microbiome. We don't fully know. The authors speculated in the paper, and I'd encourage you to look at it as well. They also looked at metabolite profiles, so essentially what's the microbiome doing. Also looked at immune cells as well. So it's a very comprehensive set of analysis that they did on the patients to try and identify, well, if this is working, how is it working? What's happening to the microbiome before and after the intervention, which was a key secondary endpoint, and what's happening to the rest of the body as a result of the microbiome changing? Like, what are the immune system changes after the treatment? What are the plasma metabolite changes after the treatment? Because if the microbiome's metabolite profile changes, then that finds its way into the blood. The last thing they did as well, which I think is really interesting, is to try and confirm their findings. They did a similar set of experiments in animal models. Now, there are limitations associated with these, and the authors acknowledge them as well. But essentially, they kind of recolonized antibiotic-treated mice with stool sourced from the individual donors, and the FMT from the donors restored the PD-1 anti-PD-1 effects against the tumors that were resistant. So that's very, very interesting because they did some additional mechanistic work to kind of confirm their results. The other things which I've written down that kind of made the study strong were that they used capsules because I think that's a more realistic, scalable route than, for example, in one of the studies they did colonoscopy, which is a tube that goes up the patient's backside. And they did no antibiotic pre-treatment as well before the patients got the FMT. They got what's called a bowel lavage, so they got some laxatives. Because there was these competing thoughts within the literature around, well, do you need to give antibiotics before FMT to improve engraftment? Some companies have tried to do that. Some companies are still doing that. And others say, well, maybe you just give a laxative to kind of flush things out and clear things out. And some companies, like us at Enterobiotics, say, no, we don't want to do bowel pre-treatment at all, because we think you get a better patient experience without the laxatives. The efficacy data, although its efficacy kind of means effectiveness, but it relates to how well is the drug working. And although it's a very small sample size, 20 patients, they did show superior outcomes to what's been reported in the monotherapy, so individual immunotherapy outcomes reported in the phase 3 trials conducted by the drug companies. But the small sample size and the absence of a anti-PD-1 arm on its own does make those results challenging to interpret. This has added a lot to the field. It suggests that giving FMT with these immunotherapies upfront rather than to patients who have had a failure to respond to their immunotherapy might improve the response rate to the first-line immunotherapy. And that's a big deal. Patients get better faster. Patients don't progress. Now, they also tried to elucidate in those that did respond what were the microbiome determinants. And they identified some microorganisms that looked like they were associated with response consistently. And more generally, they identified that the responders had a more similar microbiome profile to the donor material that went into the responders after the intervention, suggesting that they kind of accepted the healthy microbiome, and that healthy microbiome did some wonderful work within the body to its immune system to enhance the effectiveness of the checkpoint inhibitor. Now, looking forwards into the future, what does this mean? Does it mean that all patients who are getting immunotherapy should get FMT? I don't know. Too small a study, certainly, to be able to say that definitively, but that is a potential strategy. The authors also speculate, and they sort of suggest that it might be possible to determine through the microbiome of the patient who should get FMT. So not a blanket FMT for everyone because some patients respond, but how do we identify those who are not going to respond before we give them the immunotherapy through their microbiome? And then we could give them a full spectrum FMT type approach. So I hope you've enjoyed this episode on using gut microorganisms to treat cancer. As I said at the start, if you want to learn more about this specific study, i.e. doing an even deeper dive, going through absolutely every single aspect of the study, I'm very happy to do that because I think that'd be a lot of fun. I'm also happy to talk more about the other two papers published in the journal Science in 2021. If you'd like me to do that as well, so please write and we can do a specific episode on those. If you're enjoying Inside Matters, please like and subscribe. 5-star reviews are very, very much appreciated. I'm very excited about the potential of the gut microbiome in cancer immunotherapy. We've got 3 fascinating studies now published in high-impact journals suggesting that donor, full-spectrum, broad consortia, microbiome material can significantly impact on the effectiveness of these immune checkpoint inhibitors. And that could be absolutely massive for the field and, more importantly, for the patients. This is Inside Matters. My name is Dr. James McIlroy. I hope you enjoyed it.